Did it work? Yeah, up to 15 minutes. Okay, let's go ahead and get started. So first and foremost, just to remind everyone that this is a cardiovascular medicine grand rounds, give CME credit. I've written the number on the board. Please enter this number in your app to get credit for CME grand rounds today. Just to remind folks, we have a very busy next few weeks before I introduce the lectureship and our speaker. Next week, we are celebrating the Larry Cohen honorary lectureship, which will be given by Kim Eagle. Kim, as you know, is a former chief resident here at Yale and has had a storied career at the University of Michigan. We're excited to join him and welcome him to Yale next week. Following that, we have two of our wonderful fellows, Anga and Evan, who will give grand rounds. And then we have a faculty meeting scheduled on June 4th. I strongly recommend people put this on their calendar and try to do their very best to attend in person. We will have an open discussion, one of many that will continue our work towards learning more and more about how the Yale School of Medicine and Yale New Haven Health System alignment is leading to a new fund flow model and the impact for us. So welcome everyone. After that, we have the Calabrese lectureship. Just to remind everyone, this is in honor of Massimo Calabrese, and we're welcoming Noel Bailey Mertz as the Calabrese lectureship this year. The Calabrese lectureship is typically done in internal medicine grand rounds, which is Thursdays at 8:30 a.m. We also will have that same day a second lecture she will give to the cardiology community in a smaller setting, and we'll continue to send out reminders about that. And then we'll take a break June 11th. So very busy schedule coming up. Here are disclosures and credit and information on accreditation. And I just wanted to say a few words before I ask John to really lay out more information. It's really been wonderful for me to get to know Michael, and I'm so excited that we're able to honor him as one of our giants of Yale cardiovascular medicine. As you'll hear from John, we would not be sitting in this room with a faculty as large as we are and a program as big and as extensive as we have without the tremendous work that Michael and other giants did to form our section. And so really, Michael, thank you for gracing us with your presence and being such an integral part. I remind people that Michael has not retired. He did stop his daily clinical practice at the end of last year and took a very well-deserved and perhaps first a sabbatical, and he's coming back from that and will continue to work with us, particularly in helping us establish our structural heart disease program for TAVRs at the VA in the subsequent year. So he's not retired, but I think we're excited for him as he looks to different activities. And with that, I'm going to ask John to come up and say a few more words about Michael and introduce our wonderful speaker, Samir Kabadi.
Thanks, Eric. It's certainly a pleasure to get to introduce really two giants in the field of cardiology, who I've known for a long time, but Mike, you definitely are the one that I have known longer. You know, Mike started here a while back, I think before most of us were here, and served as the director of the Heart Cath Lab for over a quarter of a century. And really, right, he pioneered the first balloons, the first stents, the first roto, everything else that we were doing. But I will say that Mike's probably greatest achievement that I see is in the fellows that he has taught. I am very grateful to consider myself one of them, and there are a number here in the audience who are also one of them. It was when I was, I think, my second year after fellowship, that we had a reunion bringing back 25 years of fellows that Mike had taught, and seeing the gratitude that they have, where they have ended up in their lives, and the impact that he's had on cardiovascular medicine because of their impact on him, I think really highlights the fact that, you know, an individual alone can do a lot of things, but an individual who's been a tremendous mentor can do many, many more things. And so, Mike, we are forever grateful both for what you did here at the lab and your achievements here and in the section and what you grew, but probably even more so than the mentorship that you have given so many of us. So thank you for that. So I next want to introduce Dr. Kapadia, who presently serves as a professor of medicine at the Cleveland Clinic. He went to medical school in India and then did his medicine residency at Baylor, his cardiology and interventional cardiology fellowships at the Cleveland Clinic. Like many people, worked for a number of years. In fact, I think Mike Clement might be in that category too, at the VA as his first job after he finished his fellowship, and then that was in Seattle, and then returned to the Cleveland Clinic in 2003. In 2009, he became the director of the heart catheterization laboratory there, and then the head of interventional cardiology. And we've had some time to get to know each other. And I want to highlight some of the things because when he was there, he really led a dramatic transformation of interventional cardiology at the Cleveland Clinic. Not only what physicians were doing, but how the entire system, how the entire organization worked. He actually published that in JACC in 2018 in an article entitled Operational Efficiency and Effective Management in the Cath Lab. And while there are many members here in the audience who don't work in the cath lab, I will note that he published, his co-author in this was Michael Tushman, who is a professor at the Harvard Business School. And really what the paper highlights is not how you address a cath lab and changes that need to occur in the modern era, but how you address a health system, the complexities that are there, how you look at it from each of the different models that are there. And I would encourage anyone who's involved in sort of the changes that are going on at Yale to take a read of this. There are some interesting business models that are in there, and there are some interesting ways about how we may move forward and run things. I think in large part due to his success in transforming the cath lab at the Cleveland Clinic, he actually became chairman of the Department of Cardiovascular Medicine, where he's continued to lead one of the top cardiovascular centers in the world. He's truly a visionary leader in the field of cardiovascular medicine. I saved some trees and some forests and didn't print out his CV, but he has over 900 peer-reviewed publications and over 40 book chapters. His awards take up a whole nother page. He's from Cleveland, and I'm sure the only person that LeBron James is jealous of for their awards is Dr. Kapadia. And small note, he's received Teacher of the Year 3 times, and he's also received the Innovator Award at the Cleveland Clinic 8 times. One may ask, how do you receive an Innovator Award 8 times? Well, you have 17 patents that you've developed while you've been there. His first patent, for younger folks in the audience, came when he was an associate professor and was the director of the Interventional Fellowship Program. His most recent patent in 2022 was for apparatuses and methods for at least partially supporting a valve leaflet of a regurgitant heart valve. He's really done everything in the field. He's published, he's taught, he's won Teacher of the Years, he's had patents, and he's transformed the Cleveland Clinic into what it is now. The one thing he doesn't have is a Yale degree. We're not going to get him an honorary degree, but I think we're glad to have his son here who will beat him towards getting that Yale degree in a little while. So welcome.
First of all, thank you so much for this very nice introduction and invitation. And Dr. Clement, it's a great pleasure to have your lectureship and be here. More than anything else, I'm of course very connected because my son is doing undergrad at Yale. Also, my most important partner, Amar Krishnaswamy, he graduated as a Yale from the Yale Medical School with working with John. So even though every day I work in Cleveland Clinic, I have something to hear about Yale, that how we are working at Yale and what we learned and things like that. So I feel a little connected. So whenever I got the invitation, I said, I'm definitely going to come with a lot of pleasure. So with that, I'm going to talk about percutaneous valves. Of course, you know everything, a lot of things. So I try to keep things that are novel, interesting. Basically, even though he said that I'm an administrator and do a lot of things, I'm passionate about cardiology. I like to see patients. I take care of patients. I work in the cath lab. This is my fun part. So I'll talk about all these three things, believe it or not. So the first part to say is that we are in an era which is unique, which is very great, because Leonardo da Vinci first drew the aortic valve in 1512. Then it took 150 years to first identify that the valve gets narrowed. 150 years. So, you can imagine 10 generations of, 7 generations of people. And then it took 300 more years to get the first aortic valve replacement. 300 more years. And then it took 30 more years for the first patent by Anderson Hanning to come up with the valve that can be replaced percutaneously. So now a logarithmic scale of the time to say that we are in an era where we can experience this in one generation. So now 30 years. And when I started my fellowship, we did not have, or even when I was attending, we didn't have an aortic valve replacement. So from there, aortic valve replacement came in place in 2002, the first aortic valve replacement. And now this is a standard of care. This is something that has happened in not even one generation, one career path that we have seen that it developed. Of course, Dr. Cribier did the first valve replacement in 2002. He passed away this year, as you know. I saw him, we're close friends and mentor, inspiration for all of us. And this was end of last year that we met together, and he had an award, Lifetime Achievement Award in Korea. How did this all happen? It happened step by step, of course, but with great science. So the first study we did, I put this not because I'm the first author, but I just want to highlight this first study. So first study was to say that this is a study where we randomize the patients to nothing versus aortic valve replacement. Nothing versus aortic valve replacement, severe AS. Braunwald had already published from 12 patients, hemodynamic data to say that once you get symptomatic, you are going to die if you don't treat aortic valve. But FDA requires you to randomize the patient. And this is not small number of patients. We randomized 179 patients to medical therapy and 179 patients to treatment. And we followed them for 5 years. And in the control arm, 1 patient was alive. 20 had crossed over and 6 had outside of trial aortic valve replacement. But 1 patient was alive who did not have aortic valve replacement. So a very terrible experience because we enrolled large number of patients and many of them, I saw them die. So this was a very terrible experiment, but it was done. And this led to the first approval of aortic valve in the United States. So you can imagine that this was, and to be honest with you, in this paper, if you read one of the letters, one of the prominent cardiologists wrote a letter to us to say that the reason why this trial is positive is not because the aortic valve worked, because in the control arm, you did valvuloplasties that killed people. So I said, you got to publish this letter because at least 10 years from now, people will read this and say this was so ridiculous that this was the, it is published. So it was terrible that to say this kind of interpretation, to come up with this was, and then from that first valve replacement that was done in the United States to today, all the valves, 100% of the valves are being tracked. Lots of different trials are being done with both all different kinds of valves, randomized, published in good journals. And this is what led to this revolution. This is what, there's no other therapy that has this kind of tremendous scrutiny and publications. So the change is real. From opening the chest, when I first started, I went to Dr. Cosgrove. He said that, I said, we want to do this thing. He said, Samir, have you seen me operate? I said, not really. So he said, you have to come 100 times, see how easy it is to do an aortic. And he's right. Aortic valve replacement is extremely easy and very reproducible. But from there, to now doing it with percutaneous therapy. So now this is just an approach. All of you have the same approach, that patients are referred to TAVR. We analyze them, divide them in intermediate, high risk, see if they are seen by the cardiologist, cardiac surgeon. We discuss, and then we decide that what is the best therapy for this patient. I brought this old picture just to highlight my mentors. This is Dr. Tuju and Dr. Swenson and a lot of other young people. Sachin was fellow with us. Now he's at Methodist Hospital. Amar is there. So we were trying to, this is in person, and this is at least 15 years old slide. This is the slide that we make for all our patients to say that how we do TAVR. So this is very similar to what you guys have. And I saw that in the cath lab today, but this is to say that CTA labs, all these different things is structured to say that this is how we are going to do this procedure. This is our room, is larger. This is a hybrid room we first designed. It's a biplane room. But just to say that there's so many things, but there's nobody there. So there is a common pump available so that in case patient have to go on cardiopulmonary bypass, we can do everything within 5 minutes. This is our goal. So we published, because Dr. Cosgrove told me that once you start, when you have the first death, we will assess the program and we will decide. So we started in 2006, and in 2012, he called me and he says, there's no death. You never came. We never had a death. So the first case to 262 cases, we did not have any death at 30 days. So it's unheard of. People thought we were making it up, but it was true. I slept in the hospital. It was incredible, but we did not have a single death. So he asked us to write it. So we had 16 people would have died, but they stayed alive because we had the infrastructure to take care of them within 5 minutes. So our goal was 5 minutes. So within 5 minutes, we could go and pump, do whatever we needed to do, vascular surgery, vascular grafts, whatever. So this is the room designed like that. So we have a vascular, we have a wall for cardiac surgery equipment, wall for cardiology equipment, and one wall for cardiac, but no swine gas, no general gas, nothing like that. And we do it, if people interested in the interventional side, we do it from one groin, little different. We use a sentinel device, and we do stroke protection. We have a biplane lab. This is one of the only kind that is a hybrid room. So we have 2 cameras. And everybody has a sentinel device. We do hemodynamic assessment. And we deploy the valve in an RAO projection like this, where we isolate the non-coronary cusp. We get these radiolucent line, not a cusp overlap method, but we just take the parallax out and then we deploy. So high deployment. So if you look at in the LAO projection, which commonly we use, it looks very high. This is the same valve. It looks like it's going to embolize. It doesn't embolize. It stays in place, and it does well. And then we confirm the deployment. We use the straight flush catheter rather than the pigtail catheter classically that we use. And then every patient we analyze within good aortogram to say that there is no leak, because again, we want to be like surgery, so that when we are doing these things, we don't want to say that we did anything that is less than what is done by the best surgeons. And if AR assessment, we even reduce the aliasing velocity, make sure that there is no AR. And then we do check the hemodynamics, and we publish a fair bit of things to say that how we check the dicrotic knot. This is one of my favorite things to say, that where the dicrotic knot should be. And it has to be more than 50% higher. So this is something that is helpful. And then we design this strategy that we take the pacemaker out of the right ventricle apex, put it in the right atrium, pace the right atrium, make sure that the conduction is 1-to-1. And if it is 1-to-1, then we can discharge the patient. We did a prospective kind of analysis with Dr. Colombo, and Amar published this. Again, we didn't need any pacemaker if we could pace at 120 beats per minute. So all of these things we published. So whenever I tell my fellows that whenever you do something, publish it. So we said that, general anesthesia, a lot of people say that at that time, this was in 2012, and so, but long-term outcomes were no different, because people said, oh, we do TE, we get better outcomes. No difference. Even long-term, there was no difference in the outcomes of patients. Cerebral protection has been my favorite thing, not because of anything, because when we published the first paper in New England Journal, Dr. Schaff wrote an editorial in New England Journal saying that, oh, TAVR will work, but it is going to cause strokes because you are going to have, and the first partners trial did not have stroke as a primary endpoint. So unfortunately, it was not a primary endpoint, so nobody had a stroke analysis done. So the surgical stroke rate was only 2.4%. And it is unheard of because nobody was tested. So the surgery, how we report and all those things. So surgical stroke rate was low, and the stroke rate with TAVR was a little bit higher, not statistically different, but higher. So this led to a lot of excitement, and then we analyzed all the partner data. We showed that actually the stroke is not higher with TAVR; it's actually less. But we wanted to reduce stroke, so we worked with the Sentinel group, and we created these filters. And then we created, with Dr. Lansky, we created this NeuroArc consortium. We said that we want to protect the stroke. And the stroke was killing people. It still does. So this mortality is 16% versus 3.7%. And if they're not discharged home if you get stroke. So we did the first study, and 99% of the people had something in the filter. But the primary endpoint was the amount of strokes in the brain by MRI. And we were negative, 0. There was exactly the same. The stroke, where it happens, is more important. How much the volume is not so important, but how many particles are. So statistically, if you say that how many particles are going up and how many areas are affected, maybe that makes sense, but we didn't know that at that time. So we put the total volume as the primary endpoint. And total volume depends on even one big piece goes there that can cause a large stroke or considerable things. So it was not statistically significant. We presented to the FDA honestly to say that, listen, we got something in the filter, but we didn't see a difference. And FDA people analyzed the exact same way. They approved the device because we said that, if you are, so it was a good learning when we presented to the FDA that it was and then I designed the trial. I said that, hey, listen, we want to do the trial with a clinical endpoint. So we designed the trial with 3,000 patients. We thought that we would have 4% in the control arm, 2% in the treatment arm. This was the hypothesis. Trial was negative. And New England Journal says that you cannot publish a secondary endpoint. So the disabling strokes were less, but the total strokes were same. And disabling stroke was a secondary endpoint. So I said, okay, I'm not going to publish secondary endpoint, but I can put in the same bar graph 2 different colors. So they allowed me to put 2 different colors in the bar graph. So you can see that the disabling stroke is definitely less, because otherwise they do not allow this kind of secondary endpoint to be highlighted. But 20 versus 8. And this was statistically significant. Of course, all the things were positive in the sense that people who developed stroke didn't die as much. They went home. They did not have, disability. And the not funny, but a sad part was that outside of United States, we had 1,200 patients, and in United States, we had 1,800 patients. Outside of United States, the study was negative, 3% stroke rate versus 1%, disabling stroke rate, and 3.7 and 0.7. In United States, stroke rate is less, 2.6%. But with Sentinel, it was 1.3%. 1,800 patients, trial is positive. And 1.5 versus 0.4. So again, it is a subgroup analysis. It's not a primary endpoint. So, there are limitations to this kind of thinking. We published that again in the part of the subgroup, but of course, not a primary endpoint. So Cleveland Clinic, these are 3,000 patients. Cleveland Clinic, we have 3,000 patients. So we analyzed our data, 1,000 without CEP, 2,000 with CEP. And so about 1,000 and 2,000. And we had 15 strokes in 1,000 patients and 8 strokes in 1,800 patients. So, and out of the 15 patients, 4 died. And out of 8 patients, nobody died. So this was, again, telling us that we are preventing major strokes or disabling strokes with CEP. And that's why we currently use it in all patients. Several devices. This is the first generation device. So there are now several devices being tested. So stay tuned. The BHF Protect TAVI trial, which is the same design, 7,700 patients. So before we unblinded our study, we talked to our friends in London, and we are going to combine the data sets together upfront. So before the studies were unblinded. So out of the 7,000 patients, their hypothesis was 3 to 2%. Ours was 4 to 2%. So that's why the sample size is doubled. And this is very similar endpoints, some differences. But if you look at it, they have already enrolled. Target is 730, and they have enrolled 6,388. And they are enrolling at a rate of 180 per month. So I'm expecting 8 months will be done. So this was from May 4th. So fairly soon, fairly recent data. What are the other things we published? We said, if you deploy it high, we decrease the pacemaker rate from 13% to 5%. And left bundle branch from 12.2% to 5.3%. So this is less than half. So this is another very important part to say that how we deploy the valve is very important. And then we started discharging, this is before COVID, we started discharging patients same day. So we said there is no, so it's like a fairy tale to say that we are having a 90-year-old patient with a severe aortic stenosis. Now he's coming awake, we're talking to him, we replace his valve and we discharge him. So there was a very nice endocrinologist, 91-year-old, came from Hopkins, and he says that, I cannot imagine, it's like a science fiction. So he wrote a very nice poem and it's published in JAMA to say that when he was a student, if he told somebody that we are going to replace your valve and go home the same day, it is impossible. So he had his valve replacement on Wednesday, and Monday he was back in his clinic. He was active. He was back in his clinic seeing patients for endocrinology. So he wrote a poem like that. Anyway, so we are discharging the patient, and then we published it. Amar published it actually to say that we were very safe in discharging the patient. Currently, we are discharging about 50% of the patients home. If we finish by noon, we discharge them by evening if they don't have any complications, including conduction of the matrix. And then we see them next day. We check their groin. We make sure that they're okay. Check the ECG. We give single antiplatelet therapy. And only time we use anticoagulation, if we have a gradient increase more than 10, then we do a CTA. And if they halt, we give them 6 months or 12 months of anticoagulation. These are our data for last 6 years. So last 6 years, we have done 4,000 towers. So we are doing about 700 towers. These are everything. These are alternative access or whatever, in shock, every patient. 0.4% mortality, 0.5% stroke. AR more than 2% plus is 0.4%, and new pacemaker is 3.2%. So this is, and we are a surgical institution in the sense that our surgical data are equally good or better. So the idea is that we want to have similar outcomes. So we also looked at our surgical data and we published that to say that surgical data are very similar. They are not different, but this should be the standard. But in my opinion, we are able to treat more patients with similar outcomes because we are doing enough surgeries and enough transcatheter therapies. Low risk papers, and I have John's paper too. So to say that the aortic valve, this is the P3 study. As you know, the curves are coming a little bit closer. But still 5-year outcomes, outstanding. Stroke, rehospitalization, whatever way you cut it. But I want to point this out, that if you look at, it's not just stroke and death. If you look at people with bleeding, AKI, new onset AFib, these are serious things for these old people or even young people. So to say that it is just the stroke and death are equal, but other things are very, very different. So having an open surgery versus not having an open surgery is a big deal. So this is why people don't want to have this thing. And this is the Evolute group, and Dr. Forrest is very instrumental in this group. Again, very, very important data. 4-year now. Next year, he's going to publish the 5-year data to show that the mortality and the stroke, disabling stroke mortality, both are less, or at least not that different, statistically speaking, from surgery. So huge information to say that this technology is working in these patients equally well. And these are the 4-year data, stroke and revascular, whatever way you cut it. And hemodynamics actually better for the supraannular valve compared to the surgical valve. So you see the size of the valve better. So the question is, which patients now should we send to surgery? This was from ESC. They asked us, myself and Stefan, and then 2 surgeons, Michael Mack and Falk, to write a paper to say that, reverse paper, to say that which patient should we send to surgery. And this is what we came up with, that the surgery, if the favorable morphology, femoral access is there and the age is not too young, then surgery is not really the first choice. So what age you cut off, either 65, 70, but the lifetime management is super important. Of course, if they have other things that needed treatment, then surgery is very reasonable. And then we created this graph to say that the last treatment should be TAVI. So if you have what age and what is your life expectancy, so last part should be TAVR, and then you design. So many of these patients who are in 60s, I think it's not unreasonable to do the TAVR first, then surgery next, and then do a TAVR at the end. So you have only 2 valves at one point in time. So TAVR is so first TAVR is a better choice than TAVR, because then you have 3 valves at one point, if they are very healthy. That in 70s, you can operate on them. I'll skip this part. Bicuspid aortic valve has been challenged, and I think as you have and other people have said, that we need a randomized trial. This is the study Dr. Forrest published from the core valve to say that 3-year outcomes were very good with the bicuspid valve and TAVR compared to surgery. The SMART trial is another trial that has been, in a very important contribution to say that hemodynamics matters, and whether when the annulus is small, whether you can put a supraannular valve and people will do better. Clinically, there's still no difference, but the hemodynamics is different in this group of patients. So long-term follow-up will tell us whether there is going to be a difference in hemodynamics. A lot of people ask this question, what is happening to these patients long-term? So I got one example. So this is a 52-year-old gentleman now. So he was 40 when he came in 2012 to us. So 2012, he presented because actually he had radiation heart disease. They had done thymectomy, and now he had developed severe aortic stenosis and coronary left main and right coronary stenosis at the ostia from the radiation heart disease. So they tried to open him in Portland, and they couldn't get to the heart. So they closed him back, and then they sent him to Seattle. I used to work in Seattle. So they called me. They said that, this is 2012. So they were not doing this kind of high-risk thing. So they said that, can you please see if you can treat this patient? So we brought him to Cleveland Clinic, and I stented both his coronaries, the left main and the right. And then we put a valve. At that time, only 26-millimeter valve was available. So he needed a 29 valve, but we didn't have it. So we put a 26-millimeter valve. There was some paravalvular leak. We left it. And the patient did amazingly well. Now he's back in 9 years. Radiation heart disease. And you can see that his aortic gradient, as you see on hemodynamics, is there, but moderate. But he has a 20 millimeter mean mitral valve gradient, because of radiation heart disease, 20 millimeter. And his PS systolic pressure is 100. And he flew. He came, he's still walking. He's 52, young. And both his daughters went to college. He's so happy because they were young when he came at 41. This is how he looks. Severe MAC, severe, the valve is there, but, it's bad situation. But because of the AI, one good thing happened, his LV was slightly bigger. So he had a little bit of LVOT space in the, because of the slightly bigger ventricle. And we measured. So now we put a valve in valve. Again, no big deal. And we could even see that there is a big gap there because the valve is not large size. So, okay, yeah, he was doing fine without it, but I closed it anyway. So we now put a plug in the paravalvular leak, and we put a mitral valve. after the paravalvular leak closure, and mitral valve in MAC. So 2 valves replaced, and patient went home same day. We published it, not because of the idea is that it is possible with 100 millimeter PA pressure, 100 millimeter PA pressure. Our anesthesia, we wanted to do it with the conscious sedation, but patient said that give us general anesthesia. Anesthesiologist was upset that now how are we going to do general anesthesia PA pressure 100? But I said, guy came walking, flew from Portland, he can at least handle that much. So he did very well, and you see that patient was discharged. I don't recommend that mitral stenosis to put a mitral valve in MAC is a difficult thing. You have to be careful. You have to understand the anatomy. It is not a simple thing. But now we are doing it. We are doing it. And we published this to say that what are the things. But I want to show one slide to say that surgical literature has this kind of patients, 8, 2, 9, 20, 10. So this is a small group of patients that they have published the series. So this is the literature. So when people talk about that these are easy to operate, they are not easy to operate. But they are not easy to treat percutaneously either. 50% mortality at 1 year in these patients. So this is an important group of people. Now, of course, there are several valves. So we are using at least 4 different valves in these patients. And of course, doing it from apical is a bad idea. So you have to do it transeptal. So transeptal works well, but it is much worse than mitral valve in valve or mitral valve in ring. So I'll just skip this part, but you can do it with surgeons too. How do we do this? And I'm not going to go in details with this, so I will keep some time for questions. But the lampoon, alcohol septal ablation, we call it a cleave procedure. We designed a new procedure where, and Amor will publish it soon. So we are perforating the leaflets and putting the valve in the leaflet. So instead of cutting the valve and doing all the lampoon and all this, we just perforate the anterior leaflet of the mitral valve and put the valve through the anterior leaflet. So the anterior leaflet moves posteriorly. And we do the same for basilica. We do same for mitral valve in valve, and works like so far has worked very well. So this is something to keep in mind. Of course, we have M3, Tendyne, Sophia, all these valves, hybrid approach. Mitral regurgitation. I put this Carpentier classification to say that there is a normal valve motion, primary MR, secondary MR, mixed MR, and myxomatous valve, rheumatic valve, and of course, restricted valve. So the most important thing that is happening, so same slide. So this is an 80-year-old patient with mitral regurgitation. And as you can see here, the anterior leaflet is prolapsing, right? The anterior leaflet is flail. Surgeon gets anxious that anterior leaflet is the problem. For cardiology and for clip, this is the best because big leaflet and it's going back. So you can put a clip, and this will be, again, we started the first clip before we did the tower. We just celebrated 20 years of clip at last TCT, and it's very sad that the CEO passed away. Dr. Whitlow and I did it, and Dr. Whitlow passed away. So, he didn't see the growth of this, but still, this is a 20-year that we celebrated with the mitral clip. So it's a very image-based. So again, if you don't have good images, you can't do it. But now, of course, we have 4 valves in Cleveland Clinic. There are 6 valves that are available that are being tested. And when we do the transeptal puncture, again, everything in 3D is the key. So we used to say that this transeptal is good because it's posterior and all this. It's no good because this is the mitral valve. The needle is here. So the needle has to be here. So you can be fooled by how far down you came and how posterior you are. So if you're higher and posterior, you may be very anterior. Then you have an aorta hugger and all this kind of nonsense. So learning the anatomy is super important. Of course, I put this, so fluoroscopically, if you are in the RAO, this is lateral, this is medial, lateral, medial. So for coronary guys, if you are seeing left main bifurcation, that's where the lateral commissure is. Where you see the PDA that's where the medial commissure is. So something to keep in mind. And then very importantly, imaging is crucial. So see, we do it with a 3D MPR. I know that one of our fellows is now here and he is doing this. So the idea would be to say that 3D MPR aligned, but look at this, so beautiful. So we are able to do this procedure with such a precision that it was impossible before. To say that now we are seeing no rush and heart is beating. So you can treat the mitral valve in a way that is amazingly safe, and we can analyze where the leak is, residual leak is. We can look at from the ventricular side to understand where the leak is. And then we can decide whether we want to stop or not based on, I'll just skip this because I think it's having a problem. And then based on the hemodynamics. So we see and we feel the heart. So we can measure the pressure and we can at the same time see how the things are. And then we decide. All these things are evolving so fast that now there are a lot of AI algorithms, and we are working on several of them to say that procedural guidance. So procedurally tell people that, are you good or not? You saw this much color, this much V wave, this much things. Are you in a good shape or you're not in a good shape? So this is where things are happening. And it's very close. There are two trials, and again for discussion. So the primary trial is a trial where we are randomizing low-risk patient to mitral clip versus mitral valve repair. I almost feel uncomfortable. This is a superiority trial. This is a CTSN trial. This is NIH-sponsored CTSN trial, surgical trial. But they put a superior. I don't know how you can do a superiority trial for a new therapy, but this is what is happening. And then there is a repair MR trial, which is a non-inferiority trial for mitral clip in an intermediate risk patient. Also happened. Secondary mitral regurgitation, good article. This is by Dr. O'Gara. I corrected a little bit to say that he says secondary mitral regurgitation is disease of left ventricle or left atrium. Actually, it's disease of both. So most commonly, it's combined. It's not just one or the other. And the second thing is that it is how the leaflet compensates or not is also very important to keep in mind. So, these days, again, I'm not going to go in the details, but we analyze these patients with a 3D MPR, with a good imaging. I don't know why it is doing this, but okay, I want to show this much. So Mitra FR, and if you consider the Mitra FR versus COAPT, what is the difference? So this is my easy way to imagine. So you think of three things. You have severity of MR, you have LV dysfunction, and LA dysfunction. You say that if the patient has more MR, but not LV and LA dysfunction, like inferior wall MI, and you have a leak, posterior leaflet restriction. These patients are ideal. You treat them, they will be cured. So this is what they call a disproportionate MR. If you have, most of the people are like this, that they have some MR, but MR is there. Then these people also benefit from the clip. If you go to that level where the MR is not that much, but the LA and LV dysfunction is terrible, this is the people that the benefit may be questionable. However, you prevent tertiary MR. So the secondary MR leads to tertiary MR. MR gets more MR because you dilate more. So this at least will prevent the further messing up of the ventricle over time. Hemodynamics is very important. So if whatever we are doing, if they're not optimal candidates, these days we are able to do, I hope it plays, it doesn't. Anyway, so whole coaptation line, as you see, is leaking. And if the whole coaptation line is leaking like this, then M3 is a good option. This is a simple thing. You put a dock around the mitral valve, and then you put a valve inside of the dock. Again, percutaneous, very safe, simple, straightforward procedure to put a valve in the dock, as you see there on the mitral valve. So happening. And this is before and after. I'm going to do one thing, 1 second, so we can see the movies. I'm going to restart my program because it does that for some reason. I think it runs out of memory. So while we do this, I just want to point out that I'm going to spend 2 more minutes in the tricuspid and then we'll stop. So we have some time for questions. I know I rushed through some of the things, but purposefully so. Yeah, so now we can see it. So this, oh, it's not projecting, I'm sorry. No, it's my fault. One second. I got it. Sorry. That's okay. So you can see it here. You can see it now, right? Yeah, good. So the valve is not leaking after we replace the valve. And unlike the mitral clip, where you put a mitral clip in a bad ventricle, if you put a valve in a bad ventricle, you will feel it. The ventricle feels it. Because the annular function is very important for the LV function. LV does this as well as this. So the annular function is super important, and there is good data for that. So this is a good paper to read. So for the annular function, how the annular function helps the LV function is a very important thing. So putting a valve, so mitral clip, initially people thought it's not going to work unless you put a ring. Actually, it works better without a ring because the annular function is preserved. So this is a very important part. And now we are doing the Carillon trial where we are putting a device inside of the coronary sinus to just eliminate the MR or decrease the MR or even not MR, just remodel the ventricle. And simple procedure, simple study. We have designed a study with a sham control. And this is, of course, another passion of mine. So we are doing this. So Dr. Starling and I were the national PI, and we are enrolling it in this trial with no MR or not no MR, mild MR, moderate MR, or severe MR. And we are randomizing the patients to put the Carillon versus sham because we have to put the catheter in so we can do a sham procedure. So this is enrolling right now. We have enrolled about 20 patients. And for the tricuspid valve replacement is one of the things that now recently got approved. So, and there's so many other devices for tricuspid valve that are being formed. This is so just for a little bit of a personal thing. So the first tricuspid valve replacement we did percutaneously in Cleveland Clinic. So we went to the FDA and we said that we want to do the first in man in Cleveland Clinic. And they say you can do it because otherwise we wanted to go to outside of United States, Paraguay and all, but we wanted to do it in Cleveland Clinic. So this is a valve we developed in Cleveland Clinic. This is called the Navigate valve. And this valve we placed, this is the first, and this is myself, Dr. Navia, and this is Amar. So we did this first in about 8 years ago in this patient. And patient did very well. And just to see that how big, so this is the aortic valve. This is surgical aortic valve. This is the tricuspid valve. And just see the size. So you can see that it is a 52 millimeter valve. So, you can imagine that the 21 millimeter and 50. So tricuspid valve is a big valve. So this is where it is happening. And now the Evoque got approved. Very fancy, very nice, simple, easy device. And we are having the CMS discussions right now to say that what would be the requirement of the hospital and the operator to get this particular valve. Tomorrow is another call for that. And the relationship with the IVC is very important. Again, imaging is everything. So all these new technologies, I write many times in my note saying that, we can treat it if we can see it. So if we see the valve properly, we will be able to treat it. So it's like surgery. If you don't know good exposure, you can't do it. So this is an important thing. Imaging is the crucial part. And we designed all these things to say that how IVC relationship is important. Sometimes we do it from the left groin. So if technical things, if people are interested, we can discuss. And of course, hemodynamics are very important and things. The data are good, but just to remember that this is a breakthrough device pathway. breakthrough device pathway, total of 150, 98 patients with the device, 98 patients. So the data are relatively small. And FDA, after approval, they will say that now we follow the study patients for 5 years, and then they can reverse the approval. So this is a very different ballgame. Edge-to-edge also got approved for the same reason. And again, the clips, if you see well, you can put it, not as beautiful as the no TR, but much safer. And in some of the patients, if they don't have severe, see there are 2 clips, and very good result in this particular patient. And we did write this paper to say that the trial-limited trial is criticized because it was not sham controlled. People knew what exactly they were getting. So we tried to correlate this bottom paper to say that how much is the KCCQ compared to the TR, and there was a correlation. Of course, this is the best we can do. Susan Arnold published this with David Cohen, myself. And what can we do? Now, most of the people are excluded from these trials with too big, too large gap. So there is a simple thing to do a superior inferior vena cava valves. So trick valve is that. So this one, we did the first in man, also first in United States in 2000, like 2 years ago. So we can do conscious sedation, nothing, just put 2 valves, self-expanding valves, fairly easy. And people are doing well. So we have designed a randomized trial. Dr. Rishi Puri and myself, we are going to do the trial in United States, randomized to put a superior inferior vena cava valves. Again, tricuspid valve, working with the EP group is very important because what we do for the lead management, how you take it out, heart failure doctors, imaging doctors. So we have 7 minutes. So future is, of course, very bright, exciting. Even the current status is exciting. We have to be, as I tell people, that you have to be cautious, but you have to take some risks. And I have one simple thing from the, that the policy, this was the first Prime Minister of India, that he says that the policy of being too cautious is the greatest risk of all. So you have to take some risks, but you have to be cautious. So thank you for your attention. I know I rushed it a little bit. What?
Samir, that was a fantastic talk. Maybe I'll start with more of a physiology question, because I was intrigued by your comment around your experience with tear in LV dysfunction patients, and the idea and concept that by modulating the function of the annulus, you can get a result different than you expected. Can you expound on that a little bit? And really, it relates to your coronary sinus device. Wouldn't that lead to the same kind of effect you're seeing with the annular repair rings?
So there are 2, yes, both questions excellent. So the question is that can we study the annular motion and annular function with the LV dysfunction or not? So we are, and other people are also trying to analyze. So as you know that the annular fibers from the left ventricle go to the apex, and then there's circular fibers. So the longitudinal fibers contract the ventricle like this, and the annular fibers contract it like this. So how much is the function of the annular to apical displacement is the key question. And that number depends on how bad LV dysfunction is. So normally it is less than 10% of the EF that is contributed by this. But when people have LV dysfunction, that might be a significant amount of LV dysfunction that is contributed. Now, putting a clip decreases the AP dimension, but it does not impair the function of the annulus. Whereas when we put a new valve in, it does impair the function of the annular displacement. Then putting a ring, surgical ring, also impairs annular function. The Carillon device is a device in coronary sinus, and we published that the coronary sinus is about 1 centimeter atrial in this patient. So the idea is that it takes away the stress of the atrial muscular fibers, I didn't go into details, from the annulus. So actually the annular function improves because the atrium is not stretching it from the top. So Will Silber, he wrote a nice paper from from the Mount Sinai showing that how the atrial fibers interact with the annulus. So this is a very fascinating side to say that how the annulus affects the LV function and how the atrial muscles affect the annular. So we are analyzing all these things, but I think, as I said, it is an exciting time to learn all these things because we can do it without stopping the heart and putting them on pump.
And monitoring and finding ways to image that, that function would be very intriguing and may allow you to define populations who might do better or worse.
Exactly.
Thanks for a wonderful talk. I think you highlighted upon the fact that these procedures are fairly low risk and that there's really a collaboration in the room between the person doing the procedure and the person doing the imaging, which has become critical to it. But if you rewind back to the beginning of TAVR, that wasn't the sort of collaboration that was supposed to be happening in the room. The collaboration that was supposed to be between a surgeon and an interventional cardiologist doing it. And we really have sort of, we still have that, right? You still require that, but really the collaboration that now has to take place that is critical is between the imager and that, especially for straightforward transcatheter, transfemoral procedures. I want to, it's sort of a two-part question, but I'm curious where you view the role of surgery within these procedures. Europe's in a certain way as we fast forward 5 or 10 or 15 years. And then also, you've done a lot in education, what you view as the role of interventional trainees and folks 10 years from now. We see a decline in coronary disease, et cetera. And is, what you do and what I do now going to become really what any interventionalist needs to do, given, your data, you can send them home the same day. You can do things that really are not that different from a PCI.
So the first question is that the imager's role. So there is so the ASE is working right now in the new tricuspid valve collaboration. Again, I don't know how much is, there is a confidentiality part, but the idea is to keep imager as a part of an operator, give them a status of an operator. And I'm all for that because I think that imager should be an operator. The second question is that what is the role of surgery? I myself think that the role of surgery is very much there. The reason is not because they need for bailout purposes. So the concept is different. It is not so much for the bailout purpose, but in order for a proper selection of the patient, if you divide the cardiologist and cardiac surgery in two groups, there will be a conflict. There will not be the best care of the patient. If you involve both groups in the procedure, then there will not be a conflict. People will buy into it that this is a good therapy because they are also part of the therapy. So the idea is not so much because they provide a very different skill set, but it is because they will be partners. They are partners in the entire management of the patient. So this is the reason why I'm all for having, I actually became the first member of AATS. So AATS is a cardiothoracic surgery organization and they don't have a cardiologist as a member. I said, you got to have a cardiologist as a member, not because, it is an important collaboration to have, if surgeons are able to do all the things we do, they can do the procedure, no problem. But I think the idea is that working together is super important for the growth of the field, because otherwise people will say that, okay, we can do tricuspid valve replacement. Nobody's doing tricuspid valve replacement surgical, but they would bring all these things up because if they're doing it with you, then, then it is easier. Everybody understands what is best for the patient and you do it. So I'm personally for the collaboration very much with the surgery and surgical groups, and this will help us with future trials, enrollment, everything.
Samir, thank you so much for an excellent talk. I wanted to just ask you a little bit about about the outcomes that you described from a programmatic perspective, but then also from a national perspective as well. And so the outcomes that you describe, I mean, are absolutely remarkable, right? The mortality rate is half of what the rate is. It's less than half than what's described in the STI, the TVT registry. The stroke rate is 1/4. And so it's absolutely remarkable and done in a way that doesn't select out the sort of the highest risk cases. I think is also sort of a testament to the program that you built. And, I guess my question is, to what extent do you think that is just the team that you all have been able to build over the last 10, 15 years, sort of keep it together and then continue to iterate? And then the second part of that is, to what extent do you think many of those things are reproducible across the country? I mean, there are now almost 900 centers across the country that are doing TAVR, the vast majority of which don't have outcomes anywhere close to that. And so there's always this tension between, sending folks to centers of excellence versus allowing patients to receive care locally. Can you speak to that a little bit as well?
So I agree with you. So a lot of people ask this question, that why the outcomes are better. So that three things in my mind. So one is the culture, to say that, the first thing and foremost thing is to say that the outcome has to be better. So it's not like an option that let us check what the outcomes will be, but every patient that you are doing, all the details have to be teed up. What we do is, whenever we see the patient, every Monday for aortic valve and every Friday for mitral and tricuspid valve, we have a 2-hour meeting. 2 hours meeting. I myself join the meeting, look at all CAT scans and all angiograms, if needed, of the patient. We measure live and we do typically 25 patients. And we say that this valve is better, and everybody, all the imaging people, surgeons and cardiologists, all our team, 4 of us who are doing TAVR are there. And everybody says that what is the best thing to do. So that's number one. Number two is that during the procedure also, I go to a lot of places and people think that this is like, there is a seriousness is less in a lot of places. People play music, talk, joke. This is a serious thing. There is no reason for a procedure to be lighthearted or anything. Not that you have to be stressed, but you have to be focused. And I find that this is the most common reason why good people, have sometimes complications, because they're distracted. And so this is because the procedure is not complicated. As you know, it's a simple procedure. So if you are a reasonable person and if you are focused, it is very unlikely that you are going to mess up. But you have to be completely focused and not thinking other things. And then the last thing is the infrastructure, of course, is super important, right? The nurses, people, they call you, they find out, they're ready. We have all this infrastructure. We are fortunate. So we have all this infrastructure in place. But in my opinion, the most important thing, because I tell people that, if they present in the complication conference that, oh, this kind of things happen 5% of times, and it happened to me only once in this year, that is unacceptable. So, why it happened this time, that is what is important. Why it happens in other people, sorry, but this is, so the culture that we strive for, and that is reproducible. You can tell other centers to have certain kind of a discipline, so to say, in the procedural areas. That helps. And if there is a complication coming or happening, you have to call for help. This is another very important thing. Don't be shy. I tell people that if you have a complication with one cardiologist, it's bad news. You need to have 2 cardiologists. If you realize that there's a complication happening, why didn't you call? So this is also a very important piece in the culture. And then it is reproducible. So you can do it, I think, outside. And 5 years we have been able to do it, and we are not refusing any patients. So this is very important to keep in mind, that people on ECMO, people on Impella, and all kinds of things, they refer to us, and we never say no. We do whatever is best for the patient, not for our outcomes. If we have one death, we have one death. What can you do?
That was amazing. You could have given a very short answer there and just said it's because of you that you have all these
It's not true.
great
though.
outcomes. It's a much more involved answer, but there's an inherent risk, obviously, in all these procedures. And I'm sure that you all take two patients who look nearly identical, and one has a complication risk and the other one doesn't. And so I'm wondering if there's any attempt to either prospectively or retrospectively go back and try to figure out, are there any biological explanations or anything genetic? Is there any way you can go back and say, aha, I can figure out why, rather than just saying there's a 2% risk and that's.
No. So there's a lot of effort on this particular question, including anatomy. There's a DASI simulation, FEOP simulation. So there are people who have done AI to analyze that which people will have these complications or not. There is a huge effort from from experimental side to say that how we can predict groin complication, these things. So there is a lot of effort ongoing to say that we want to make it safer and safer. And now there is an 8 French aortic valve. So there is which is already, one of my colleagues and friends developed it. So there is a lot of development that are happening for the aortic valve. So 8 French aortic valve, you can imagine. You cannot do radially yet because it expands to 12, but you can do it in the groin in 8 French, and because it's a iridium, it's not a stainless steel metal. So you don't need so many struts. Thickness is the same, but the struts are less, so you can crimp it.
Be 100% transfer.
100% transfer.
We know.
Yeah, I agree.
Well, anyway, thank you very much,
Pleasure.
Samir, for this presentation. Again, we recognize Dr. Clemens for developing percutaneous valve program here, and all you've got there. So, thanks, everybody.
Thank you.
Yeah.